What we'll be talking about for the next half hour is ultrasound of the painful scrotum, but we'll be dividing the talk into the sections that you see up here, introduction and technique, and then we'll go through a bunch of the different scenarios that cause pain. And as Cindy kind of alluded to in her talk, we're just really blessed because the ultrasound manufacturers have given us better hardware and software pretty much every month. So this was the first published ultrasound paper by Fred Sample. It's a bistable image showing a hematocele. And the technology has just gotten so much better that we see these incredible images, like this, the trapezoidal field of view. This was polyorchidism right here. This was an 80-year-old asymptomatic gentleman with a testicle that looked like a bowling ball, but since he was asymptomatic, we never got any follow-up on that. And then similarly, the color Doppler is just so much better. Now we see the incredible flow like this throughout the testicle. And in the old days, we really had to work to try to get any flow in there. So technique is important in almost everything in ultrasound here. So just to kind of go back to some basics here, I always tell our residents, take a towel and put it tightly over the thighs and then put the patient's scrotum on top of that, because otherwise you're kind of digging between the legs trying to find the testicles, and instead you want the scrotum elevated on a platform there so that you can get to it. We want to use a machine capable of demonstrating flow in all normal testicles. That was an issue in the past, but now pretty much any machine that you buy is going to show flow 100% of the time in normals, and that's crucial because we're going to say if there's no flow, it's torsion or something bad like that. And then use a really high-frequency transducer. There's lots of technical reasons, Doppler, Rayleigh scattering criteria, etc., but don't use your linear probes for vascular or your curve linears unless it's a really huge basketball-sized scrotum there. And we do have to be a little bit careful because the new machines are so good. We're seeing bits of shadowing from little air bubbles in the gel, or in our older patients, we'll see a striated appearance to the testicle. So you don't want to overcall that as leukemia. That's just normal. We're seeing things that we didn't used to, as Cindy mentioned. So by definition, we're looking for low volume, low velocity flow, as opposed to the aorta, which is high volume, high velocity there. And so you want to choose, different manufacturers have different terms, scrotal package, testicular package, small parts package, kind of offensive, but you have all those different terms there. But what that's doing is that it's optimizing flow for low volume, low velocity flow right there. If you really want to get into your machine, you can do this individually here. So in color Doppler, you want to minimize your pulse repetition frequency. That's just another term for the velocity scale there. Maximize your color gain until you get noise right there. Minimize your wall filter settings. Remember that a high wall filter takes out low volume, low velocity flow, so you want to minimize right there. Tell the machine to always show color rather than grayscale if it has a choice, as opposed to the opposite there. And then if you're really into it, you can go deep into the machine and maximize the number of sound pulses per color line until your frame rate gets too slow there. Power Doppler is a lot easier to optimize. And again, the beauty of ultrasound in the scrotum is that we generally have the other side to compare to. So here's one of our residents scanning. All the good cases come in the middle of the night. So this was at 11 o'clock at night. Rule out testicular tumor, or rule out torsion. And you can see that Josh did a really nice job, showed that there's good blood flow within there, and that this is not a torsion, that this is a tumor. But note that he grabbed the low-frequency vascular probe there. This is the 6 megahertz probe you can see on the top yellow arrow there. And then a couple minutes later, he wised up, and you can see change to the 14 megahertz probe. And look at how much smaller and tighter the dot size is on that one. And then here's another one, just an example of all good cases come in at 3 in the morning right there. So Jeremy's scanning right here. Calls absent blood flow, says that it's torsion, but this guy had had his testicle removed on the contralateral side years before for a previous torsion, and had his velocity scale at 0.04 right there. Well, it took the urology team at least an hour and a half to come in. My pointer's not really working well up here, but you can see at 4:43 they came back in, or Jeremy went back in and said, wow, let me bring my scale down to 0.008 at that point. And there he's down into the gain. So he's decreased his PRF to the absolute minimum and has proven that this is a torsion. There is absolutely no blood flow there. So now let's talk about anatomy here. And we can divide the 3 vessels that supply the testicle. The only one that matters is the testicular artery right there. You have the deferential and the cremasteric, but they really don't count in keeping the testicle alive. Remember that the testicles start embryologically up in the upper abdomen as a ridge, then they migrate south. So their arterial supply, their venous drainage, and their lymphatic drainage all come from the reason of the renal hilum. Some of the older urology textbooks, or some of the new ones, still talk about taking just a continuous wave, the dot tone, putting it in the supratesticular area and looking for flow. And they say if you see flow, it's not torsion. And that's completely false, because in the supratesticular area, you have the testicular artery, which we see on the right here, which has that nice low resistance waveform. A millimeter away from it, we have an RI of 100%. And presumably this high resistance is either the deferential or the cremasteric artery, but your doptone's going to pick that up. And if your testicular artery's out, the testicle's dying. So just pretty much ignore the supratesticular area and focus on the testicle itself. So the testicular artery comes down from above. It runs along the back of the testicle right here. This is the capsular artery right here. And then it gives off the centripetal branches coming down towards the mediastinum testis. And then they do a U-turn, and these are the recurrent rami here. And 10 to 50%, depending who you read, you get the transtesticular artery, which comes through, but then arborizes in this fashion. And if you're like me, the only reason I got through medical school without flunking out was on the strength of this guy's phenomenal drawings. But I put this one in here because this is probably the only mistake he made in his entire life, because he shows the vessels coming in at the hilum and radiating out, and that's not correct. This slide is in backwards just to provide a homologue, but you can see the capsular artery here coming around, then the centripetal arteries, and then the recurrent rami. And here are some gorgeous cadaveric microangiograms that demonstrate this anatomy. Capsular artery coming around, capsular artery coming around. Here's one of these transtesticular arteries, capsular, then centripetal branches coming down here, and then recurrent rami coming right there. And here's an older unit showing the capsular artery, newer units showing some of the centripetal arteries here. Remember that we have to get blood flow within the testicle. Just showing the capsular artery is not enough. And here's a newer machine showing some of the beautiful vessels we can see. Occasionally you can see the accompanying vein here. And this is the very first color Doppler unit ever made out there, the quantum unit. And you can see it's kind of like an Atari video game with those little blocks right there. But you have the recurrent ramus coming back up. So flow characteristics, your RI should be around 60% inside the testicle. The exception to that is prepubertal boys, and then it may you may have an RA of around 100% there. So it's normal prepuberty to have no end diastolic flow there. And if somebody comes in with pain, always, always, always address the mass. If they come in with pain and a mass there, because one of the frustrating things for clinicians is they say, well, my patient Joe hurt, I felt a mass, and all I got back in the report was a normal ultrasound. So you always want to say, I put the probe on the area where I felt the mass, where the patient palpated the mass, and I looked right there, and it turned out to be X, Y, or Z. And in this case, it was just an epididymal cyst, and we were able to reassure this kid who was terrified, who thought he had a testicular tumor there. But always specifically address any masses in the testicle. So now starting with issues here, this was a gentleman who was carrying a .22 caliber pocket pistol inside his jockey briefs there and had a negligent discharge. And you can see kind of going right through there. So I guess this is a cause of testicular pain. But one of the more common causes that we see is testicular torsion. But in the non-traumatic acute scrotum there, basically the differential is torsion versus acute epididymitis. And clinically, it's really hard to distinguish between those most of the time. And time is crucial, because torsion, you've got to get them to the operating room right away to untwist it to save the testicle. And the grayscale findings totally overlap. So the 80-20 rule or 90-10 rule is that if you see no blood flow in the testicle, it's torsion. We'll talk about some exceptions to that, but absent blood flow, the first 10 things out of your mouth are testicular torsion. This is a disease of young men right there. It's preceded by trauma, sexual activity, strenuous activity, cold weather. The underlying pathophysiology there is contraction of the cremasteric muscle, which kind of pulls the testicle up. And then you have this underlying bell clapper deformity where the testicle spins and loses blood flow. And this is what I love about academic medicine, where they give us really precise numbers, like anywhere between 19 and 68%. So pick your number right there. But a big chunk of people who present with torsion had a history of similar pain that resolved spontaneously, meaning that they torsed and then they just got lucky. They kind of wiggled a little bit and it spun around and it went away and they dodged the bullet that time, but the bell clapper deformity is still there, so they're going to come back in another year or so. And this pathophysiology we've all seen right here. This is from a gorgeous article by Dr. Prando here, but the normal tunica doesn't encompass the whole testicle here. So the testicle is fixed or pexed or attached. Those three words mean the same thing posteriorly. And here's an axial view showing that it's attached back there. In the bell clapper deformity, the tunica comes all the way around like that, all the way around on the axial plane. So I guess the first guy that described this said that it looked like a bell clapper, and so that it spins around there. And obviously, if it spins around more times, it's more severe. You have a more acute, blood flow cut off there. Different cell types within the testicle are different resistance to it, to ischemia. But roughly, if you can untwist the testicle within 7, 10, 12 hours, somewhere in there, you have close to 100% salvage rate. Once you go beyond 10 or 12 hours, your salvage rate just plummets and you end up having to do an orchiectomy. So that's why this is a real emergency here. And when I was a resident, we still did nuclear medicine, but that's pretty much gone the way of the dodo. Here's a case that we called testicular torsion there. You can see a photopenic area in the right hemiscrotum. He went to the operating room, and this was an infarcted seminoma. So ultrasound's faster, it's cheaper, it gives you much better morphologic detail there. It's got all the advantages over nukes, even in the peds population now. So in terms of grayscale findings there, what we want, Bill Middleton taught us this, as he's taught us so many things, but you want the testicles to look normal. If the testicles look normal on grayscale, those are the ones when you go to the operating room and you can untwist it and they pink back up. The minute the testicle starts looking bad on grayscale, those are the ones they end up having to do an orchiectomy on. So here's just an example of a normal one. You can see on grayscale, the testicles look completely normal up here, and on color Doppler, there's no blood flow. And here are two different patients showing ones that we missed. Here the right testicle's normal, here the left testicle's normal, and then the infarcted torsed testicle is enlarged, hypoechoic, and all that stuff. These both went to orchiectomy. And here's one, this was 24 hours of ischemia, and this kid just noticed it playing basketball, kind of gutted it out. Here's the normal right testicle with good blood flow in it, and just look how heterogeneous and bizarre the left testicle is here. Here's just a cine clip going through it. And I went to the OR on this one, and this was literally black, so obviously they had to do an orchiectomy in this case. So normal grayscale appearance is good. The minute it starts looking bad on grayscale, we probably waited too long. And again, if you get a really stoic patient, or this is from Dr. Prando's article in South America where people didn't have access to healthcare right away, you'll have patients coming in presenting with a mass because in the past they had a torsion. The testicle spun around and around and around. It rose to the upper portion of the hemiscrotum right there. And so people are thinking that this is, a testicular tumor there. But in reality, it's just a torsion. The acute pain's gone over. It's kind of risen up in the hemiscrotum. So keep this in your differential for a testicular mass. And the literature shows that if we have no blood flow on color Doppler, we're really, really accurate at calling torsion right there. You can see this one, just the blood flow coming down to the testicle. Normal arterial blood flow is symmetric, so we've all seen these. Here's the normal right, here's the normal left, two different patients, and a torsed testicle right here. And in the old days, when machines weren't so good, we said that if you saw blood flow in the testicle, it wasn't a torsion. But as Cindy talked about, the machines have gotten better and better, so we have to nuance that a little bit. And here's a patient where we see blood flow in the testicle there. We put a pulse Doppler tracing on it, confirmed that it had a spectrum, but this is what it looked like in the operating room. But this really isn't a diagnostic dilemma because the patient hurts on this side. You compare to the other side, which has 10 million times more blood flow right there. So remember that seeing a little bit of blood flow like this could just be a testicle that's spun around 1 or 2 times and hasn't completely infarcted, but you still need to go to the operating room there. Here's just another patient showing good blood flow on the right side, decreased but present blood flow on the left side. The spectral waveforms are a little bit different right there. And again, this was a partial torsion that had just gone 180 degrees instead of, multiple times around. And then something that people have been talking about more and more recently is the segmental infarction here. And this is where those two other vessels, the deferential and the cremasteric that we talked about before, have come in. But sometimes you'll get just an infarction, and most of the time, 80%, it's the upper pole of the testicle right there. And it's important to make this diagnosis because this is treated just with Motrin, with NSAIDs. You don't go to the operating room. And this is kind of a classic appearance here where it's heterogeneous, no blood flow in the upper pole, good blood flow in the lower pole there. And again, we want to make this diagnosis to keep the patient from going to the operating room. Now we talked about the 80-20 rule, so let's talk about the exceptions to absent blood flow means torsion. One of my favorite surgeons, this guy had the best bedside manner. It's straight out of an Atul Gawande article there. He was just a lovely human being, but I've seen over 6 cases from him where when he did hernia repairs, he tightened down the ring too much. So you want to, keep the bowel from going down there, but you can't just close it off because the testicular artery is going through there. And he just always cinched things down too much. And so you look at this one and you think, oh, is that a torsion there? Nope, this was right after a hernia repair, and he tightened it down too much and the testicle died there. Fortunately, all these guys were elderly, but still, it's not something you want to do. Here's another one here. This is not a torsion. This is after a hernia repair. We've got our pulse Doppler gate as big as we can get it, our PRF down low, no blood flow. This is an infarcted testicle after hernia repair. Here's yet another one. You can see a central infarct following the hernia repair right there. This is not a tumor. This is not an abscess. This is an infarct here. Epididymal orchitis, another cause of pain. So you can see the classic C shape of the epididymis on all these views right here. Normal epididymis on grayscale imaging. Here's from Paula when she was at AFIP, how abnormal the epididymis looks when it's hyperemic and infected there. And again, epididymitis typically looks normal on grayscale. If you wait too long, that it gets enlarged and hypoechoic there. So here's the normal epididymis here. Here's the enlarged hypoechoic epididymis over there. And again, normal epididymis up here. Here's the globus minor or tail of the epididymis. And look how thick the corpus is right here. So typically in epididymitis, the infection starts in the outside world, goes down the urethra, comes into the vas deferens, goes to the epididymis, then goes to the testicles. So typically when you have an epididymitis, you usually have an orchitis along with it. Here are just 2 more cases of epididymitis there. Could this be a seminoma? I guess it could be, but one of the advantages we have in ultrasound is we're able to talk to the patient. He had discharge, he had fever, he had a history of STDs, so we were comfortable following this, and this went away with time right there. You can see normal blood flow in the epididymis with our new machines. We didn't used to say that in the old days, but now you can get blood flow 100% of the time in non-infected people, but just compare to the opposite side, and the side that has the epididymitis will be really hyperemic. Look at how hyperemic this epididymis is here. And look at how incredibly hyperemic this epididymis is up there. Look at the skin thickening here. And you look at this one, the epididymis is just red hot there, red hot epididymis. It's swollen. Look at all the blood flow. And we have the concomitant orchitis, the increased blood flow within the testicle there. Well, we in medicine thought that we were really bright, that we made this association of orchitis when patients have epididymitis, that we were the first to discover that. So here's just another example of epididymitis and orchitis there. Let's see, what else here? So complications of epididymitis, we talked about the orchitis. It's a bad disease. I'll always remember this case. This was an incredibly sweet kid who had Down syndrome, couldn't communicate to us. We did his ultrasound and blew it. We call it normal. 3 days later, he came back with pain, and we finally did the job that we should have done the first time. We looked at not only the testicles and the epididymis, but we looked at the whole scrotum backward attached to the perineum there, and he had this big abscess back at the base of the scrotum. So please remember to always check not only the testicles and the epididymis, but check the whole scrotum there. And when I stuck a needle in this was pure pus here. Here's Fournier's gangrene, just gas there. Here's another case where you can barely even see the testicle due to the gas around there. And then again, we said most of the time when you see no blood flow in the testicle, it's torsion, but we saw the hernia as the exception to this. And here's epididymitis. When the infection gets so bad in the orchitis, you get a microvascular infarction of the testicle, and this testicle's dead because this kid didn't take his antibiotics. Here's another one here. There's the Pathophysiology there. Look at the skin thickening up there. And here is the normal testicle for comparison. On the 11th, he came in with almost no blood flow in the testicle. 3 days later, and again, he hadn't taken his antibiotics. He's now in the hospital on IV antibiotics. We have reverse diastolic flow. This looks like a renal transplant that infarcted the vein there. And I've seen 5 cases of reverse venous flow, and every single one of them's gone on to orchiectomy there. So epididymitis is not a good disease if you don't take your antibiotics. Normal ultrasound 12 days before, didn't take his antibiotics. Now he has an abscess in his testicle there. Here's another one. This was called a tumor, which is good for the outside folks because masses in the testicle are malignant till proven otherwise. But he gave us a history of orchitis so that when we went to the operating room under ultrasound, we biopsied this, and this came out to be an infarct/infection. And so we bivalved the testicle, cleaned it out, but he kept his testicle instead of getting an orchiectomy there. Orchitis grayscale findings, it can be normal on grayscale, or it can be a little bit swollen and hyperemic, as we see right here. Here's bilateral orchitis with reactive hydrocele and very hyperemic throughout. And again, ultrasound, or the literature shows that ultrasound's pretty good for the diagnosis of epididymal orchitis. 3 mimics of epididymal orchitis there. Remember how we talked about 19 to 68% of people had a history of similar pain that resolved spontaneously? So if you happen to scan somebody, this is one of our medicine attendings who woke up in the middle of the night with the pain, then when he came in the next morning to see us, the pain had gone away, but look how hyperemic his testicle is here. And because he had no risk factors whatsoever for epididymal orchitis, urology explored this asymptomatic individual and found a bilateral bell clapper deformity there. So when the testicle torses and then spontaneously detorses, you get a reactive hyperemia. Leukemia. There's a barrier for chemotherapy getting into the testicle there. So when patients with leukemia and lymphoma recur, they often recur inside the testicle. Pattern number 1 is cannonballs, so we're going to suggest that. But pattern number 2 is just an enlarged, hypoechoic, hyperemic testicle, which we might say is orchitis. But you talk to the patient, and he says, oh yeah, doc, I finished my chemo for leukemia 6 weeks ago. This is recurrence of leukemia right here. And then the final thing, particularly in the pediatric age group that mimics torsion or epididymal orchitis, is torsion of the appendiceal appendages there. So you have them coming off the epididymis, much more commonly off the testicle. This one looks like a duck right here. And you can see this one coming off the epididymis, this one with Bugs Bunny ears right here. Here's one coming off the testicle with good blood flow in it. This makes up a big chunk of the acute scrotums in the pediatric population because fortunately our pediatric population is generally not getting STDs and epididymal orchitis that way. But when you have this appendix of the testicle and it twists, it really, really hurts. But the only way you treat it is you give them Motrin and goes away. And this thing infarcts, it falls off. And this is one of the big causes for the so-called scrotal pearl or scrotal boulder right there. And patients often palpate these, so as we said at the beginning of the talk, just put your finger on it, confirm that that's what this is. It's not intratesticular. This is just an old torsed appendix of the epididymis or testicle. This is from Phil Rawls here. This is the mother of all scrotal pearls. Look at the size of this thing. And as he was rolling it around, you could just see this thing like a bowling ball go back and forth. If you go to Moline, Missouri, Olean, Missouri, you can participate in this. This was given to me by Jason Wagner here. So we don't have the time to talk about testicular tumors in this lecture, but in medical school, I was taught that testicular tumors are a painless mass. That's false. 10 to 50% of the time, pick your number, they infarct and they hurt. So just because somebody has pain, don't say, oh, testicular tumors have to be painless right there. So there's just lots of examples of testicular tumors. Here's a mixed germ cell tumor. This kid was playing basketball, got nailed there. Here you can see the hematocele, the big blood clot right there. Here's just an unusual testicular tumor. This is a Leydig cell tumor right there. But again, testicular tumors can hurt, so know your intratesticular mass differential. Here's a mixed germ cell tumor. And then let's move on to trauma here. So trauma, again, 15% of patients with testicular tumors present following trauma. So just because somebody has trauma and you see something, don't just say, that's just a hematoma and be done with it. Now, most of the time, for various medical reasons, patients with testicular trauma always go to the operating room. It's the exception when they don't. So here, this just looks like a disruption of the tunica albuginea. Here you can see the blood up there. This turned out to be an intratesticular hematoma, but could this be a seminoma that ruptured? Absolutely. So if these patients do not go to the operating room, it's incumbent upon us to follow these up and make sure that they melt away. And these may take a month or two to go away. They don't just evaporate like that. Here's another one. This was proven to be an intratesticular hematoma with a big blood clot next to it. But could there be a seminoma hiding in there? Absolutely. So follow them up. Here's kind of an interesting case given to me by a friend of mine, Cynthia Nodell. She was doing her fellowship down in San Diego. And this gentleman came in with 3 months of scrotal pain, just kind of low-level nagging pain. And Cynthia does the ultrasound, and she's like, you know, this is kind of funny looking. It doesn't really look like anything I've ever seen before. And she's a really smart gal, so she went ahead and made the connection and got the plain film here. Well, this gentleman was a bodyguard for a not such a legitimate business. They had gone south from San Diego into Mexico. There was some dispute over the terms of the transaction there. Somebody pulled out a gun and started shooting, but it was a .22 caliber gun. He was wearing a leather coat. The bullet went through the leather coat into his testicle, and there was so much adrenaline going on that he didn't even know he'd been shot. 3 months later, he comes into the ER at UCSD. So if you have somebody with scrotal pain and you see something like this, put, cryptogenic shot in the testicles in your differential right there. Varicoceles here, really quick. We all have seen varicoceles. We know what they look like. This can cause pain, but it's more kind of a dull, low-level pain right there. Here's just a lot of examples there. There's an association of varicoceles with infertility, although newer literature says that the association is much weaker than we used to think it was right there. It's probably only when you have a big varicocele that it's associated with infertility. The key thing about this is to remember, as we said before, the gonads started in the upper abdomen and they migrated south right there. And so the left testicular vein goes into the left renal vein. You have a 90-degree angle right there. So if you have a varicocele, it could just be the run-of-the-mill varicocele, particularly on the left side, and statistically that's likely what it is. But what if you have what if you have a renal cell cancer up here? What if you have a lymphoma up there? So look at this varicocele here, and here's the renal mass, and there was the renal cell carcinoma. Here's one of our hand surgeons who noticed just pain when standing during long operations there. He has hydro on the left side. He has all this adenopathy sandwiching the aorta and the spine right there, and you can see all that. So our protocol is anytime we see a varicocele, and realizing that it's almost always going to be normal, particularly on the left side, but take 2 seconds. Just go look at the renal hilum and make sure that there's not some huge mass up there. You can have intratesticular varicoceles where the blood backs all the way up. So these are not testicular lesions. This is actually blood flow in the testicle here. So this is a little bit unusual. Hernias, we've got the world's expert on hernias with Cindy Rapp here. She's got a whole great lecture on it. But patients come in with scrotal pain, and it turns out that they have a hernia. So we want to answer the question, not just do a scrotal ultrasound. So you can see with Valsalva, this coming all the way down the inguinal canal right there. Here's a farmer who was really stoic, didn't come in to see us until the crops were in. His scrotum was the size of a basketball there with all these bowel loops. Here's a beautiful Netter diagram showing what's going on right there. And again, I always thought hernias, well, it's always bowel, and that's actually the minority. So here's another one where we can see bowel coming down there. But most of the time, it's actually properitoneal fat. And the first couple times I saw this, I was like, wow, what is this? But it's kind of an Aunt Minnie after you've seen this a few times. So here's the testicle with this huge mass sitting next to it right there. And that's actually the properitoneal fat coming down. And here's just another one here you can see with Valsalva. We have the fat coming down next to the testicle. So after you've seen a couple of these, you'll be able to suggest that. And then the last thing, in the interest of time, I'll just skip this one, but basically you can have testicular vasculitis that gives you pain and infarction. This is just an older case showing photopenic area on nukes, hypoechoic there, no blood flow on the left side. We called this a torsion, but it turned out to be polyarteritis nodosa. So you can have good pastures, you can have Henoch-Schönlein purpura, but the vasculitides can give you absent blood flow in the testicle as well. So we talked about the importance of technique, really focus on torsion because that's an acute emergency. Epididymal orchitis is a little bit more common. The three mimics of epididymal orchitis, and those are spontaneous detorsion there, leukemia, and then torsion of the testicular appendages. Remember that a big chunk of testicular tumors present with pain. They're not painless right there. Trauma, remember, not every mass in the testicles, just a hematoma. It could be a seminoma that ruptured right there. Varicoceles can give you low-level pain, so always check the renal hilum to make sure that there's not a lymphoma or a sarcoma up there. Hernias can give pain and vasculitis. So this is a 42-year-old who came to the ER with 3 hours of scrotal pain. Here you can see this is the right testicle here, here's the left testicle, and here's color Doppler on the right, here's color Doppler on the left. And this is really hyperemic here, but there's no blood flow down there. We're getting blood flow up here, but no blood flow down there. And just look at how heterogeneous and patchy the testicles are. I mean, you always want to worry about tumor, but this wasn't really discrete like a tumor there. And you can see as we're doing this cine clip, as we go through how totally heterogeneous the testicle was. And we were completely at a loss. You know, we were thinking bilateral testicular tumors, that doesn't fit. He didn't have an infection, didn't have a history of leukemia right there. But then he was actually pretty forthcoming about what caused this. And this is actually a sexual practice where you take rubber bands and cause ischemia to your testicles there, and he left them on too long. So I learned something from this case about testicular infarctions there.